Hi, my presentation today is going to be a discussion of low-dose naltrexone and inflammatory bowel disease. This is basically a repeat of a lecture I gave at the LDN Research Trust National Symposium February 2020 down in Bahamas. I'll want to start out by describing and defining inflammatory bowel disease, or IBD. So there are two major types that we're going to talk about in this lecture. The first being ulcerative colitis. Ulcerative colitis is limited to the colon or large intestine and involves small to large continuous sections or segments of the large intestines. On gross presentation under colonoscopy, you would see ulcerative lesions. Crohn's disease, or CD, involves any part of the gastrointestinal system or tract from the mouth to the anus. Lesions can skip normal segments of tissue. So you have some diseased tissue followed by some normal tissue followed by some more diseased tissue. This is called skip lesions. The appearance is thickened walls, constricting lesions, fat wrapping, fissures and fistulas, and on gross examination via colonoscopy, for instance, you'd see a cobblestone appearance. The one part of inflammatory bowel disease that we will not really be focusing on during this lecture is microscopic colitis. While this is associated with diarrhea, and to be diagnosed you must take a biopsy sample because examination grossly will show pretty much a normal pattern of tissue, but under microscope you'll see a disease state. This slide illustrates nicely the types of ulcerative colitis. So on the left you have normal tissue followed by an image of tissue with ulcerating lesions. On the right you see different aspects of the severity of ulcerative colitis. You can have proctitis that involves just the very lower end of the large intestines. You can have distal colitis, extensive, and then pancolitis involves the entire segment of large intestine. This slide actually shows what Crohn's disease looks like in the caricature. The left is normal mucosa, normal walls. On the right, you see the cobblestoning appearance of the surface layer of the mucosa. You see fissures illustrated, thickened walls, and fat wrapping. Here again is another situation that you see or can see with Crohn's disease in late stage or an exacerbated form. You see stenosis, and as a consequence of stenosis you'll see a pre-stenotic dilatation. That's where contents from the colon can't get through and it dilates. Here also we see illustrated a fistula. Here, just for a bit, I'm going to discuss some differences between gender, race, and this disease process of inflammatory bowel disease. As far as gender goes, women, especially of childbearing years, are more susceptible to autoimmune disease than are men. However, in the United States, ulcerative colitis is slightly more common in males, while Crohn's disease appears to be more common and frequent in females. It is recognized that there is an increased risk of colorectal cancer in patients with IBD, particularly in long-standing and extensive ulcerative colitis. There also appears to be an increased rate of intestinal cancer in those with Crohn's disease. As far as race goes, African Americans and whites predominantly have Crohn's disease, while Hispanics, i.e. Mexican Americans, predominantly have ulcerative colitis. There also appears to be a situation with African American descent and Crohn's disease where there's a significantly higher incidence of IBD-associated arthritis and eye manifestations. In some studies, it appears that Caucasians had a stronger family history of IBD and colorectal carcinoma compared with other ethnic groups. This slide actually shows symptoms of IBD sufferers, such as abdominal pain, mouth, stomach ulcers, diarrhea, rectal bleeding, loss or change in appetite, fever, weight loss, fatigue, and changes or loss of menstrual cycle. Some of the long-term complications of IBD are malnutrition and malabsorption, anemia, perforated bowel, fistulas, strictures and abscesses, eye soreness and redness, swelling and pain in the joints, osteoporosis, and increased risk of colon cancer. Patients will often ask, well, what leads to IBD? There are a few things. Genetic predisposition of an individual, i.e. certain genes or gene SNPs. Environmental triggers, such as food allergies, I would have to put that kind of at the top of the list. Stress, both physical and emotional stress, and environmental toxins, whether heavy metals or mycotoxins. Abnormal or autoreactive immune response. And then you have dysbiosis, or bacterial antigens, for example. I will discuss in greater length as this presentation continues, but mucosal goblet cells are protected by mucus layers to shield them from bacteria in the gut. And that's both the good bacteria and the bad bacteria. With dysbiosis, or disruption of the normal microbiota of your gut, there is a breakdown in the mucus layer and bacteria does invade. So the tight junctions are disrupted and zonulin levels are released, resulting in a cytokine release, inflammation occurs, and lesions develop in the mucosa and deeper tissues, leading to the pathology that we see in IBD. Well, this is a kind of complicated slide, but it sort of illustrates what I said previously. So you have genetic susceptibility or predisposition, you have immune dysregulation, you have abnormal bacteria in the gut where commensal bacteria take over, and you do have some environmental factors such as smoking, non-steroidal anti-inflammatory agents or drugs, and things like appendectomy can disrupt things too. You have overuse of antibiotics, poor diet, and enteropathogens. The Paneth cells, which are the leading cells that produce protective mucus, can be affected by gene alterations or aberrancies in the NOD2. You have also innate and adaptive immune responses, inflammation, and endoplasmic reticulum stress and autophagia. Interleukin 10 and some of these other markers can be used to quantify that. This talk is actually focused on the use of low-dose naltrexone or LDN and the gut, so we're kind of focus a little bit on that. The use of LDN in gut health will actually help modulate T and B lymphocyte production. This has an effect in a very positive way on gut health. LDN actually reduces inflammation and the cytokine storms that are sometimes occur. Some of these can be measured in the laboratory. We can draw blood and check for interleukin 6, interleukin 10, IL-12, IL-17A, something called tumor necrosis factor alpha, and something called transforming growth factor alpha, or TGF alpha, or TGF beta, amongst others. Reduction in inflammation reduces permeability in the gut, i.e. can reduce leaky gut. In addition to its effects on some of the interleukins, LDN also stabilizes toll-like receptors, or TLR, and one in particular TLR4, to decrease microglial activity and reduce cytokine release or cytokine storms. This is one of the unique mechanisms of action for LDN, is its particular effect on TL receptors. LDN also shifts immune system from predominantly T helper cells, Th2, to a more friendly TH1. And in this case, you see less inflammation. We also see an effect on TH17. Now, T helper cell 17 gets its name from interleukin 17. And there seems to be a reduction in activity with the use of LDN on TH17. TH17 is known to contribute to autoimmune disease. LDN can also improve GI motility, and since we know that can be a problem with IBD, we can see that helpful in some issues with regards to constipation. There are several mechanisms of action for LDN. One is an increase in endorphins and enkephalins, which will lead to the enhancement of your immune function. There is the process of inhibition of pro-inflammatory cytokines, and this leads to the improvement of the inflammatory reaction. There's also the interaction with the opioid growth factors, or OGF, and OGF receptors, which promotes DNA synthesis, which leads to the healing of mucosal ulcers. You also have the blockade of opioid receptors in the GI tract, which affects the number of liquid bowel movements, healing and repair of mucosal tissue, thus the improvement in Crohn's disease activity. And finally, one MOA is the regulation of Treg cells and the production of interleukin 10 and TGF-beta, thus downregulating TH17. This slide is borrowed from a lecture given by Dr. Weinstock, who is a gastroenterologist and leading investigator into LDN in clinical practice. Here you have an intestinal lumen with the lamina propria and the epithelium layers, and then down below you see the blood vessels. So on the very left and right of this image you see normal mucosal function as far as intestinal lumen and the mucosal layer, and you have cells back to back with good tight junctions. In the center you see a kind of a disruption. You don't see the mucosal layer and the mucus on the mucous membranes. There is disruption. The cells are a little bit spread apart, accounting for the breakdown of the tight junctions. And then what you see is bacteria, both good and bad, and viruses and other things, and large proteins like your gluten proteins can actually permeate through or leak through, hence the term leaky gut. And that becomes something that goes from the outside, which is the lumen, to the inside, which is the blood vessels. And this triggers inflammation and cytokine releases, and that's you see the activated T cells, and then you see TNF alpha and interleukins, and they cause an increased permeability that leads to actually permeability of the blood vessels. This all will eventually lead to tissue destruction and tissue damage and the development of antibodies that will attack our own tissue, hence autoimmunity. This is the birthplace of autoimmunity here. I'll now briefly touch on acute phase intestinal inflammation. As one would see in Crohn's disease, the early translocation of bacteria leading up to the breakdown of tight junctions between the cells and cascading effect of worsening gastric permeability will lead to a heightened immune response by our bodies and the activation and further inflammation leading to autoimmune disease. LDN suppresses this in the translocation and activation phases. LDN upregulates Treg cells or T regulatory cells to slow down this process. LDN will improve innate immune regulation, reduce inflammation, and improve the vascular integrity by way of reduction in prostaglandins. Support of the microbiome with adequate and appropriate probiotics, removal of any and all food triggers, and the allergens that allow for LDN to work more effectively. You need probiotics but they work hand in hand. You can't treat the leaky gut without good absorption of LDN and vice versa. Probiotics tend to be, from research, more helpful in ulcerative colitis than Crohn's disease. So once again, they work hand in hand. You can't have good resolution of your IBD symptoms and condition without LDN as a treatment option, and you can't have a healthy gut without addressing the dysbiosis. And you can't have good absorption of your LDN if you've got a gut that's on fire. So don't forget that the gut, when you prescribe LDN, and dysbiosis, or SIBO, will interfere with LDN function and promote AI. You have to resolve the dysbiosis and resolve any gut microbiota issues at the onset to yield better benefit with your LDN therapy. Now, I'm talking about LDN therapy for other things other than healing IBD. I'm talking its use in other autoimmune diseases, its use in cancer therapy, in depression, and in pain control. So again, the go factor in healing the gut is the gut microbiome. The role of the gut microbiota. Autoimmune, IBD, for example, patients have far less diversity in their gut microbes. This has been seen in research. Low levels of butyrate-producing bacteria predispose one to increased intestinal permeability and also autoimmunity. Mucin-degrading microbes also support proper mucus barrier function, and those with autoimmune show low levels of mucin-degrading bacteria. Gut microbiome also affects the T helper cell, or TH17 cells, Treg cells, and we know that TH17 activity and autoreactivity are associated with AI. And again, we see the connection between gastric permeability and the use of LDN. If you have increased intestinal permeability, it may interfere with the way LDN works on the gut, and vice versa. So you have to consider both when you're prescribing this as a therapy. This slide sort of brings everything together to show that how important the microbiome is related to all types of autoimmune disease. At the top, you see things that can be problematic or can interfere with the body's immune system or cause it to ramp up, and that's infections with viruses and bacteria and all other kinds of pathogens and parasites. You have diet. So if you're eating the standard American diet, which is an inflammatory diet, that can also make things worse. Drug therapy and hormones. Hormones have to be in balance. So an imbalance in hormones can cause you to have a higher risk for autoimmune. There are some drugs that actually can exacerbate. And of course, there's genetics, either genetic SNPs or predisposition. Then you see things kind of trickle down to several different types. Here they talk about autoimmune uveitis and rheumatoid arthritis, also type 1 diabetes, which is an autoimmune type of diabetes, and then MS is also listed here. But there are many more. In a lecture given a number of years ago by Dr. Holtarf, he talks about the importance of good microbes in the gut. So different intestinal bacteria can stimulate differently the Th1 to Th2 response. So Strep, Thermophilus, Lactobacillus species, and Bifido species can have an effect on this, and they're found in fermented foods. They can kind of stimulate the Th2 aspect of things. There are other microbes that also contribute to the robust butyrate production. And certain probiotic supplementations containing certain species of Lactobacillus and Bifidobacterium have been shown to decrease inflammatory markers. So autoimmune patients exhibit increased levels of IL-10 and decreased levels of tumor necrosis factor, IL-6 and IL-12 when appropriate probiotics have been administered. In an animal model, the administration of butyrate-producing lactobacillus attenuates the development of AI. When using LDN and IBD, there are a few other agents that will assist the LDN so that you have a successful treatment. Herbals, for example. You have aloe vera, andrographis, wheatgrass, curcumin, boswellia serrata, or frankincense, and you also have omega-3 fatty acids and evening primrose oil. High-quality probiotics such as VSL number 3, Biocult, that's out of the UK, and bacteriophage or phage therapy, along with spore therapy, and S. boulardii are also highly recommended and used appropriately. Vitamin D, a rather familiar supplement to many, has anti-inflammatory properties and also immune enhancement properties. It is a hormone, not a vitamin by definition, since our bodies do create it when our cholesterol in our skin is exposed to UV radiation. As we sit out in the sun, sunbathing, for instance, we will create our own vitamin D. So this actually is by definition not a vitamin, but by convention we call it as such. Everyone associates vitamin D with healthy bones, but its number one function really is as a hormone related to our immune function. To help heal our gut, L-glutamine is used, or a version that may be better absorbed. It is the preferred fuel or food for enterocytes and colonocytes. L-carnitine can also reduce cytokines, so that is sometimes helpful to be used. Wormwood, a type of Artemisia herbal, it happens to be an anti-parasitic, is sometimes helpful as well. And for those with really weakened immune systems and low global Ig immunoglobulins, colostrum may be used. And when appropriate, IVIG can be used. But if you can use the alimentary tract, it's better to use colostrum. And finally, but probably most important, is an anti-inflammatory diet. So you have ways of testing for this, or you can do the elimination diet, where you eliminate foods that may be triggers, and or you can check IgE, IgG, IgG4, and some types of complement against foods that may be inflammatory. Gluten and dairy are big on the list. They're like number 1, number 2 on the list of inflammatory foods for many people, not all, but many. And then there's the paleo autoimmune diet is one example. The elemental diet is another example, but it is kind of harsh and difficult to have patients follow through. Many people may come into your practice with the knowledge of IBD because they had experienced diarrhea, constipation, irregular bowel habits, and they've seen a gastroenterologist who has probably performed a colonoscopy with biopsies. They may have done some CT studies or barium studies. So sometimes people come into your practice with a definitive diagnosis of a type of IBD, whether it's ulcerative colitis or Crohn's disease. Sometimes people don't, and they don't really want to go with the invasive procedures. So there are a couple of tricks that we pull out of our magic box that are non-invasive blood tests that you can use to diagnose and monitor people with IBD. One of them is caloprotectin, and the other is lactoferrin, and they can be measured in the stool, and they tend to be elevated in IBD or other types of inflammatory bowel conditions. So it's not specific necessarily for just ulcerative colitis and Crohn's disease, but there could be other inflammatory bowel situations like an acute gastroenteritis that can cause these two markers to be elevated. I tend to use them in my clinical practice to kind of narrow down and sometimes discern the difference between IBS and IBD. And I also use it when I have a baseline of folks with elevated calprotectin and lactoferrin at the onset of a treatment course. And as we progress through the course of treatment and have resolution of some of their symptoms, to check these two biomarkers again down the road can give you sort of a number to look at instead of just subjective feedback from your patients. So they are useful in that sense also. I would be remiss with a discussion of IBD without mentioning IBS. So sometimes these can be confused. They can be overlapped. They're not mutually exclusive. So you can have IBD and IBS. IBS may be more common, and oftentimes a case of IBD may be missed because people are focusing on the IBS situation, so Irritable Bowel Syndrome. But IBS and SIBO are also linked. The name SIBO should really be called small intestine mucosal overgrowth because it's oftentimes not just bacterial, but it could be other organisms such as yeast and other types of parasites. So we're trying to have a move to have it renamed so that it becomes more comprehensive. There are a couple of ways you can check the blood for the presence of IBS. And these are relatively new tests, and they are probably not available through your typical LabCorp or Quest diagnostics, but utilizing specialty labs for these. One is called anti-vinculin antibodies test, and the other is an anti-CDTB antibody test. And those are blood tests that are non-invasive that can be used to clue you in for IBS. There's also the breath test. That is very popular amongst my peers, but not so much with me. I think IBS is IBS, and dysbiosis is dysbiosis, and SIBO is SIBO, and I don't think that digging further for hydrogen sulfide containing or methane producing SIBO is of any real great clinical value. It may be great for research, but when it comes down to brass tacks, you're going to treat SIBO anyway, pretty much the same way. One might give you a little bit more difficulty in resolution, but I don't think it's worth doing these breath tests, which most people don't interpret very well, and they're technically kind of difficult. They're not greatly reproducible, and they're wrought with kind of frustration for both the clinician and the patient. So I don't really care if it's HS or methane producers. I'm just tackling SIBO in general. I'll give a little bit of a summary of LDN on the gut. So we're looking at OGF-mediated modulation of T cells and B cell activity. You're looking for decreased inflammation. You're looking for decreased permeability, repair of mucosal lining, toll-like receptor stabilization or stability, and increased motility. So all these things can be achieved by the use of low-dose naltrexone. At this point, let's talk a little bit about the mechanisms of action for LDN. But before we have a good understanding of the MOA for LDN, we need to understand what opioids do to the immune system. So there is an opioid modulation, and it's not a very good one actually. So studies have shown in the past, when researchers looked at the use of opioids from morphine to other synthetic opioid agents, it has an effect on decreasing the effectiveness of the immune system, both the innate and the acquired immune system. So we do know that this is a negative effect, and since naltrexone is an antagonist, it is shown to have the opposite of a negative effect, so i.e. a positive effect. Okay, so let's talk about opioid receptor involvement. So opiates are known to inhibit IFN alpha and IFN beta production by normal lymphocytes and fibroblasts. Experimentation shows that inhibition of IFN alpha and beta production by opioids is reversed by opioid receptor antagonists such as naloxone and naltrexone. Because naltrexone or low-dose naltrexone are competitive antagonists of opioid receptors mu, kappa, and delta, naltrexone can either block opioids or actually displace them from the opioid receptors. If you use the sort of sophomoric key and lock analogy of drug and receptor, the binding of the antagonist drug is like turning the lock in the opposite direction. By blocking or regulating opioid receptors, This allows for upregulation of endorphins and enkephalins, which are the body's natural opioids, and they are central in modulating the immune system. Opioids, for example, have the effect of suppression of endorphins and enkephalins, and thus suppression of normal immune function. There is a vast body of information and research that shows that opioid exposure to the immune system has a modulation in a very negative way, causing the host to become more susceptible to infections and cancers and autoimmune disorders. With naltrexone, especially low-dose naltrexone, the opposite occurs from what you see with opioids, in that the immune system is actually enhanced to regulate it in a very positive way, a positive way that affects T cells and B cells to support a more appropriate response to cancer cells and invading microbes and also autoimmunity. It is interesting to note that beta-endorphin-induced enhancement of natural killer cells, or NK cells, activity may suppress the B cell function. And remember, B cells are the ones that throw out the antibodies. Beta-endorphin also exerts a direct inhibitory effect on the antibody production, and this is important in autoimmunity. So we'll see in autoimmune disorders, the enhanced cytokine level may, via stimulation of the production of beta endorphins, exert a negative feedback loop on the antibody production and potentially the production of autoantibodies. This is one of the major mechanisms of actions of how LDN works on autoantibodies and autoimmune disorders. Yet another mechanism of action of naltrexone is its interaction with toll-like receptors, or TLRs, and the subtype TLR4. So TLRs lead to the production of pro-inflammatory cytokines when receptors are activated. Pro-inflammatory cytokines increase inflammation. Again, in the short term, that's not bad, but in the long term, that's detrimental. Naltrexone is an antagonist of TLRs, and thus naltrexone inhibits the pro-inflammatory cytokines and inflammation. TLRs in innate immunity are responsible for autoimmune diseases when enhanced signaling or stimulation occurs. Yet another mechanism of action is the downregulation of TH17. TH17 and interleukin 17, of which it's named after, is linked to autoimmune diseases. TH17, like its sisters TH1 and TH2, are part of the intra- and extracellular immune system. TH17 is connected with autoimmunity. When out of control, TH17 allows the body's immune system to attack itself. LDN regulates Treg cells, or T cell regulatory cells, interleukin 10, and TGF-beta, thus reducing chances for autoimmunity and controlling the progression of autoimmune disease. LDN causes a shift from a predominant Th2 to Th1 response. Think of Th2 as outside the cell and Th1 response as those inside the cell. We would rather have a more prominent Th1 in an autoimmune prone person than a rampant runaway Th2 system. So let's talk about dosing. Dosing really matters. There's a big difference between the standard naltrexone dose used in folks with opioid addiction and alcoholism. It is a different mechanism of action. Think of it as almost entirely a different drug in a sense. So with higher doses, you have delta opioid receptor antagonist activity, inhibition of T, B cells, and natural killer function, inhibition of IFN gamma and IL-2 production. In your lower doses, where we sort of live with low-dose naltrexone, you have delta opioid receptor agonist, and we'll explain that in a bit about the very short agonistic and then degradation so that it unlocks the receptors. It stimulates T, B cell, and NK function as opposed to the higher dose, and it stimulates IFN gamma and interleukin 2 production. Why dosing is important and when? With something we call chronopharmacology, the timing of the dose. Now this is actually under debate amongst those that work and research with LDN, and I think the tendency to dose strictly at nighttime is being relaxed a little bit. However, certain properties do occur with evening or nighttime dosing. When taken at bedtime, the short-acting LDN binds to the receptors, which leads to a brief blockade of the opioid receptor, somewhere between 2 a.m. and 4 a.m. during stage 4 and REM sleep usually. This blockade is believed to upregulate vital elements of the immune system by causing an increase in endorphin and enkephalin production. It also increases production of LDN receptors or naltrexone receptors with this short blockade. Dosing at bedtime is optimal for this reason. So LDN is considered anything from 0.5 to 5 milligrams POQHS. Dosing a patient is variable and must be titrated to the individual. There's no test or no questionnaire to give the patient to determine the proper starting dose or where they may wind up. Some people might need to start at 0.25. Some people end up at 3 milligrams, some at 4.5, some at 5 for a more therapeutic dose. But really, it's trial and error for the most part until we are able to devise a test or a genetic markers maybe that will allow us to put a more clear picture on a starting ending dose. But right now we don't have that. And for those that cannot tolerate the oral dosing for whatever reasons, and I'll go over some of the side effects, but they're usually very mild and minimal because again this is a very small dose compared to the usual 50 milligram dose used in opioid addiction treatment programs. But there is a transdermal base you can use, a 1% formula, and again that can be used to titrate up and down like you would with the oral dose. Let's talk a minute about the pharmacokinetics of naltrexone. Now most of this data comes from the larger 50 milligram dose, but you can make some correlations with the lower dose. So the oral duration onset may take up to 3 days. So dosing it and having failure after one dose is atypical, and you'll have to tell the patient they must be a little bit patient, take it for at least a week or so before they toss it aside. Bioavailability 5 to 40% in the healthy gut taken orally. Transdermal, we don't really have that much information. So again, gut health is very important to absorbability of naltrexone, and it's best to dose naltrexone on an empty stomach for better absorption. But you can see from this that the oral absorption is minimal and very susceptible then to an unhealthy gut. Protein binding is about 21%. And the metabolism is via hepatic in the liver with an active metabolite 6-beta-naltroxyl. Elimination, the half-life is said to be anywhere between 4 to 6 hours. The half-life of its metabolite, the beta, is about 13 hours. 53 to 79% is renally excreted. This is the drug and the metabolite. And 100% of it is eliminated within 24 hours. Don't forget, if somebody's on LDN and they're going in for elective surgery, it is wise to stop this treatment or therapy about 3 days in advance of their surgery. Because if anesthesia or postoperative, they use any kind of opioid medication, it'll actually be blocked. Even at low doses of naltrexone, it does have a blocking potential. And the morphine they receive postoperatively may not work, so you gotta warn the patient. Most anesthesiologists are aware of naltrexone and its pharmacokinetics, but it would be a shame to have a patient enter an operating room for elective procedure and not know this, and then unfortunately suffer a pain state because the naltrexone is blocking any opioids used. So please keep this in mind for educating patients about this drug, its use, and its use during elective procedures. I'll discuss some untoward or side effects of the LDN, although extremely rare. I would have to say that number 1, number 2, and number 3 on the list would be sleep disturbance. Sometimes insomnia, and oftentimes patients will report having an improvement in sleep. That's by far the majority of people will say their sleep is improved. Oftentimes it's reported they have vivid dreams. I would not say nightmares like what you normally see with higher doses of melatonin, but rather interesting or dramatic or scintillating dreams. That's what's normally reported. Other lesser side effects are nausea, which usually ameliorates as the days go by with consistent dosing. Hair thinning, I've only witnessed once or twice, and again, it may have been something else, but it does appear in the literature. Mood swings, headache, and mild disorientation are also claimed as side effects. Again, very rare. Now let's go back to our discussion of IBD. So there are some conventional therapies that most people are aware of, and I have enumerated them here, that are pretty effective. Some are very effective in some patients, but they are kind of wrought with a lot of side effects. Some of them have pretty atrocious side effects like methotrexate and chronic corticosteroid use. So here I'll pause for a minute, let you guys make notes if you need to on these substances used in more traditional or conventional therapies for IBD. Another newer agent, which I'm not a big fan of, is the monoclonal antibodies, or the MABs. They're not really drugs. They're referred to as biologics or biosimilars. Biosimilars are sort of the generic versions of the originals that have come out. With the advent of MABs, there is a push to use them by many conventional GI specialists. I mean, it's the new kid on the block. They're being heavily promoted by drug reps, and usually you can't escape an office without mentioning of these by a GI specialist or rheumatologist for a lot of these disorders. The concomitant use of LDN and MAB can be attempted and has been in clinical practice and done effectively. While not ideal, as the mechanism of actions are actually oppositional and they can kind of compete with one another, it has been done clinically with adjunctive and symbiotic effect. The ultimate goal, and my goal, especially in clinical practice, is to reduce and/or eliminate the dependence on monoclonal antibody biologics and replace it with LDN as the mainstay of therapy. There is a push to keep folks on MABs, and this comes with a warning here, which is more of a marketing ploy than true science. The drug reps will say, "Hey, stop the MAB now, and and if you need it later and restart it, it may not work." I don't know how much truth there is. I think it's more, again, marketing and politics versus true science. Below are some examples, the generic and brand names of some of the more common MABs that are available today. And this lecture, of course, is 2020, so probably in 2 to 5 years from now, this number may double or triple. But Humira, and Remicade and Stelara are very commonly used ones in IBD. This is a little bit of tongue-in-cheek with me. Again, I'll reiterate that monoclonal antibody drugs or biologics across the board are not my favorite, as they interrupt or interfere with our immune system and make us more susceptible to infections and cancers. All you have to do is listen to the last few seconds of a commercial for one of these drugs for psoriasis or for whatever they're pushing it for, to know that there are some major issues with infection and cancer with these drugs. So I refer to them in my practice as screw-you-up-a-mob. If we look back at what happened in 2009, a new drug came on the market, or a new biological came on the market, Reptiva, and it hit the market in 2003 and was pulled in 2009 because of an issue with progressive multifocal leukoencephalopathies that were just not tolerated, and I suspect several more will follow in the future. I think we'll start to see, as these drugs hit the market and are utilized and more data is collected, that their safety will really be called into question, and I just have to tell you, prescribe these with caution. So I would be remiss to present information as valuable as this on inflammatory bowel disease and the use of LDN if I didn't provide some evidence-based medicine. Again, I always tell my listeners that EBM is kind of biased, and it depends on whose evidence you're listening to. For every study that's reported in a peer-reviewed journal, a week or two later, there'll be another study as powerful that contradicts it. So you have to take this at face value and with a grain of salt, and always question these studies, and always, be a critic. A good clinician is a good critic of what they're placed before them. And I think with a critical eye, you become a better practitioner. This is a study published in the Journal of Clinical Gastroenterology back in 2014 by researcher and gastroenterologist Dr. Weinstock. And what he did is he took a number of patients with Crohn's disease that failed some traditional therapies, and he placed them on 4.5 milligrams of LDN for about 40 weeks. And the outcome was actually pretty good. 15 out of the 33 patients had clinical improvements, and some of them went on to have improvements that were studied under colonoscopy. 11 of the 15 responding to therapy had colonoscopy showing 8 with complete healing, 1 with partial, and 2 with no new healing of lesions. Even though this was a small study, the N was very low, it does illustrate the usefulness of LDN, especially in those patients resistant to other therapies. This is another study published in 2011 in the Digestive Disorder Science Journal by J.P. Smith. She and some other researchers looked at the use of LDN in folks with Crohn's disease. They followed these folks for about a 12-week course, and they utilized something called a CDAI. That's basically a Crohn's disease activity index, or a score. It's a kind of a questionnaire, and also endoscopy. And they found that there was a 70% reduction in the CDAI score, 88% in the LDN group, and 28% in the control group. So this against control or placebo showed a difference, a good outcome. Endoscopy showed remission, 33% in the LDN group, but only 8% in the control group. This is a study published by Dr. Lai back in 2018, so a more recent study. And basically, low-dose naltrexone induced clinical improvement in 74.5% and remission in 25.5% of patients. Naltrexone improved wound healing and reduced endoplasmic reticulum stress induced by some other agents and bacteria. Again, this is another study that purports the benefits of using LDN as a therapeutic. Another study by J.P. Smith and others published in 2007, again, look at CDAI scores and improvement. And yet another study published in 2013, again by J.P. Smith and Dr. D. Field, looking at the safety and tolerability of LDN in children. Again, you can pause this presentation at any time to kind of go back and review and read in detail these slides. But in the interest of time, I'm going to go through these fairly quickly. This is an interesting study published in 2018 in a foreign journal, the Journal of Crohn's Colitis, where researchers looked at the use of LDN to actually reduce the dosing of other medications used in treatment of IBD. So their findings were that the initiation of LDN in IBD, and that's both Crohn's disease and ulcerative colitis, followed a reduction in dispensing of several drugs considered essential for the treatment of those IBD conditions. While the wealth of clinical studies and publications have to do more with Crohn's disease, there seems to be a paucity of those directly looking at ulcerative colitis. But here we see a study published in 2013. It was a case study looking at a young 18-year-old patient with ulcerative colitis who actually responded to the dose of naltrexone. While not a placebo-controlled double-blinded study, this is just a case report of successfully treating ulcerative colitis with LDN in a young adult. This was another interesting Norwegian study published in 2017 looking at LDN for IBD and the utilization of other meds. The study actually demonstrated a minor reduction in the use of weak and strong opioids after starting LDN. This is another study that was published in 2016 by Dr. Lai and Dr. Fuller, and it looks at the wound healing effects of LDN, as I mentioned before in my discussion about leaky gut and LDN. So naltrexone may have a beneficial effect in the treatment of IBD by directly stimulating epithelial wound healing and reducing intestinal ER stress, hence healing of the mucosal tissue. As we see, Dr. J.P. Smith is a frequent publisher of papers on LDN and inflammatory bowel disease, and here she's presenting and published something in the Journal of Clinical Gastroenterology 2013 on the safety and efficacy of naltrexone as a therapy in children. So don't be afraid to use this therapy in the young as well as our older folks with IBD. Yet another report in 2014 showing LDN use in those resistant IBD cases. So the data showed that IBD patients refractory to conventional treatment, LDN may be promising, as 30% of those with severe cases responded to treatment, with 20% of patients showing lasting benefits. The relative mild side effects of LDN is attractive and can justify this consideration. Also, people ask, how long do you take LDN? Well, I tell them, how long do you want to stay well? So when you stop or cessation of therapy of LDN, you can have a relapse or recurrence of the inflammatory condition in IBD, but also things like cancer and some other reasons that we prescribe LDN for folks, it's pretty much long-term therapy. So people with a malignancy that responded to LDN, who have cured their cancer, their solid tumor, let's say, they should be on LDN for life. Because the risk is if they stop or cease therapy, then there's a chance of recurrence. So it's not like a chemotherapeutic agent where you give for so many courses or so many months and then stop. This is a lifelong therapy. So the take-home message here after this presentation is that LDN appears to be safe and effective in treating ulcerative colitis and Crohn's disease. And this is by evidence-based medicine publication in journals and review articles. LDN is also low toxicity and low cost. LDN has additive effect owing to its different mechanisms of action. Concomitant use of biologics, those things called monoclonal antibodies, for long-term appears to be safe and effective. So no fears with using both of these together, even though their mechanisms of actions may be quite different. I always tell folks, use the least harmful intervention, LDN versus MAB or other meds. Use the least invasive testing, colonoscopy versus stool or blood markers or biomarkers, as a way to guide therapy and measure remission or flare. I'm sure most of your patients would rather have a simple blood test or stool test than have the prep and the procedure of a colonoscopy. And don't be afraid to use LDN with other traditional interventions, such as the MAB class of biologics and biosimilars. Also, rule out IBS and SIBO, S-I-B-O. And lastly, don't be influenced by Big Pharma on marketing of newer, more expensive therapies. That may not be something that has stood the test of time, and always remember, newer is not always better. Finally, in parting, I must say, always be a patient advocate. Do what's in the patient's best interest, not in the interest of the pharmaceutical rep who wants to be your pal coming to your office and buying you lunch. Towards the end of this session, we'll have an opportunity for Q&A, and this will be a live format. So please check your schedules to make sure you don't miss out on this. It'll be a segment open up to all attendees who are logged in to be able to have a live interaction with several of the lecturers and have an opportunity to ask questions on this and other topics and lectures given today. And this will follow the end of each day with, again, a live Q&A session. You must be logged in to participate.